Good afternoon, everyone. It's a great honor to have the opportunity to present my PhD topic entitled Current Management of Endometrial Cancer. I am István Madár, and I am a PhD student and an obstetrician and gynecologist at Semmelweis University. We believe that every endometrial cancer patient's life quality and length can be improved using novel methods. So this is the reason why our mission is to improve the management of endometrial cancer patients by applying up-to-date scientific results. In order to fulfill our mission, we have proposed two major projects. In our first project, we investigated the role of transvaginal ultrasound and magnetic resonance imaging in the preoperative stratification of endometrial cancer. And in our second project, we investigated the role of systemic therapies for recurrent or advanced endometrial cancer. So let's move on to our first project, which we have begun in March 2023, and we have finished in February this year. What about endometrial cancer? Well, endometrial cancer is the most common gynecological cancer, being one of the leading cancer-related death causes among women. So myometrial infiltration plays a crucial role, and it has prognostic factor. So its proper preoperative assessment is actually would result in reduced number of unnecessarily extended surgeries. There are two common techniques for preoperative myometrial assessment, which includes transvaginal ultrasound, magnetic resonance imaging. As the number of women diagnosed before the age of 50, diagnosed with endometrial cancer is increasing, there is an increased need of fertility preserving operations. However, only women with a low-grade endometrial cancer can opt for the fertility-sparing operation. So our clinical question at this topic was whether transvaginal ultrasound have similar performance as MRI in the preoperative myometrial infiltration assessment. And by answering this question, we believed that we would reduce the costs and the unnecessarily extended operations through better preoperative patient stratification. We have done our systemic research in the three major databases, and in the end we obtained more than 7,600 articles, but at the end of the day only 18 articles provided be eligible for the final data elaboration. So let's move on to our results. When, regardless of the endometrial cancer grade, we took all of the patients, then the sensitivity of the MRI was slightly better. However, this difference was not statistically significant, and you can see that the heterogeneity is moderate in both cases. If we take a look at the specificity, we can observe that the transvaginal ultrasound performed better in terms of specificity, and you can see that the heterogeneity is a little bit elevated. Only 4 studies provided enough data on low-grade endometrial cancer patients exclusively, and we can see that the sensitivity of the transvaginal ultrasound was slightly better. However, this difference was not statistically significant. On the other hand, when we observed the pooled specificity, the specificity of the MRI provided to be significantly better. So we could have concluded that both imaging methods provided similar performance in case of all-grade endometrial cancer patients. However, in case of low-grade endometrial cancer, MRI was better in terms of specificity. Translated to clinical practice, this would mean that if we talk about all-grade endometrial cancer patients, transvaginal ultrasound should be the first choice. In case of low-grade endometrial cancer patients, however, we see the point of using MRI as well, especially in case we consider fertility-preserving operation. Our article has been accepted in February this year, and it has been cited already twice. So let's move on to our second project, which is about the systemic therapy for recurrent or advanced endometrial cancer. I have already highlighted the the burden of endometrial cancer, basically. And I have to add that 1 out of 5 endometrial cancer patients will have recurrent disease or advanced disease. Unfortunately, there is no standard care for second-line systemic therapy. In case of recurrent or advanced endometrial cancer, the gynecologist can obtain either for local radical therapy or systemic therapy, which can include hormonal therapy, cytotoxic therapy, and advanced therapy, or the combination of these. So our clinical question was whether combined therapy protocols offer better survival than single-agent protocols. And indeed, we hypothesized that the use of combined therapy protocols offer better survival rate. Initially, we have conducted our research back in 2023 in March, but as this is an emerging field in gynecology and in oncology especially, we have redone our research in May this year. And in the end, we obtained more than 16,000 articles. And at the end of the day, 124 articles were suitable for data elaboration. Due to the lack of time, I'm going to present only some of our results, concentrating on progression-free survival at 12 months. And as you see in this forest plot, there was only 3 articles in our pool comparing the combined therapy protocol with the cytotoxic-only therapy protocol. And actually, combined protocol was better. However, this difference was not significant. If we have done actually several single-arm analysis, and if we take a look at the mTOR inhibitor pathway, we can see that the 12-month survival won't reach 15%. On the other hand, if we take a look at the PDL inhibitors, then the 12-month survival actually reaches almost half of the patients. Here you have a summary of our subgroup analysis, and obviously the comparison between the 2 chemotherapeutic methods. And so this is where we are right now. We are at the data extraction of the second of our second search, actually. And to sum up, we would like to submit our article in the next month this year. And reaching this milestone, actually, in my scientific career, I'd only just present you my scientific activity in the recent years. For this, I'm really grateful for my PhD supervisor, Gábor Szabó. Obviously, we have further plans, not only on the field of endometrial cancer, in which we would include actually the research of microRNA, the ultrasound features, and the molecular classification, but obviously in the ultrasound of endometriosis and the assessment of other gynecological malignancies with the ultrasound. And finally, I would like to thank you for your attention with the quote of Leonardo da Vinci: "The noblest pleasure is the joy of understanding." Thank you very much.
Can we go to the first project, please?
Yes.
So here you carried out diagnostic meta-analysis.
Yes.
And you compared MRI and ultrasound diagnosis.
Yes.
But it was not, for example here, so I see on the left side the ultrasonography and on the right side MRI.
Yeah.
But how did you compare them, or what was the gold standard?
So it's really a good question. Due to the lack of time, I didn't enter too much into details. Basically, we took in our pool, so we conduct only studies conducted based on a head-to-head analysis. This means that all of the patients have undergone both transvaginal ultrasound and magnetic resonance imaging. The gold standard was the post-operative section, histological section. So that was the gold standard.
So you had 3 diagnostic methods, basically. Yes.
So basically, yeah, yes. So there was 2 intervention and 1 comparator. Then we can reformulate that.
You can call it inventor. And how did you compare then these 2 methods? So how did you tell if they are significantly different or not different from each other? The ultrasound and the MRI.
Whether they are significant or not significant.
Yeah, because you mentioned
yes,
which was equal or superior.
Yes. So the significance was compared by our statisticians, judging on the pooled sensitivities and specificities of the each imaging methods.
Okay. Sorry, because I just didn't see it from this graph, but now it's somewhat clearer. Thank you.
I see. Okay, thank you very much for your question.
May I ask you, you said that one is better for the low-grade tumors.
Yes.
And that was your conclusion, right? If you go...
So the MRI
was
better in terms of specificity.
Yeah, and so I look at this, and that just what he said. I don't know how you compare it. Is it better? I'm not a statistician, so is it better? How do you compare the 2 in a diagnostic meta-analysis? There must be a way. Which statistical test one uses to compare both? Is it?
So one way to do it that you have the confidence intervals.
Yeah,
and then
I saw
you have
that.
a method, not directly. You have an indirect method to compare them. So you can do that. So I don't know because I was not a statistician for this project, but that's why I'm asking.
So the confidence interval.
But from that you can back calculate the standard error, then you can pull them together, and then there is a way to do it.
Okay.
I mean, it's not as good as putting the whole thing, the 3 arms, the 3
Right.
diagnostic methods in one model, but that's also acceptable.
Because you have the same control, or because you have it. Okay. Let me go just your conclusion slide, which was confusing to me. We're here to find errors, right? But if I write a paper, it would be like, you could find 1,000 things. So, but then implication for practice. And you say, for all grades, I gotta use transvaginal ultrasound. Unless for low grade, where I could use MRI. But you don't know what you're gonna have afterwards.
We see a particular benefit of MRI in case of low-grade endometrial cancer, but especially at patients who desire fertility sparing. We see
for better staging and surgical
for a
planning.
better staging.
And surgical planning, maybe.
Yes, for the better surgical planning.
But that was not a question of your study.
Yeah, it was an additional outcome, actually. So
But you don't have the surgical output. I understand that for better surgical plan, and we do it, for example, I'm trying to extrapolate. For prostate cancer, the MRI helps me, the nerve dissection and so on. But that was not the question you asked. The question you asked was, how do I detect better?
Which one is better? Yeah,
Right.
That was the
all
question.
grades, TVS seems better.
Yes. So TVS seems to be the first choice, to be suitable. When we have to decide between the 2 methods, we have to take into consideration the advantages and the disadvantages of the 2 methods. And we know that ultrasound is cheap, reproducible, easy accessible, suitable for more patients than MRI, for example. And hence, we can draw actually the conclusion that this can be the first choice, because actually our null hypothesis cannot be dropped, yeah? But MRI can provide additional information in case of low-grade endometrial cancer patients. This is what I don't know whether this was your question, but...
As far as I concern, I'm afraid that it's not a question what to apply, MRI or ultrasound. I would recommend to apply both, because if you take into consideration merely how deep is the myometrial invasion, that you can use both, but both methods could have some additional advantages. For example, MRI could detect the metastasis, while ultrasound probably not. And if you take into consideration that every tumor needs oxygen and fuel, then it seems to be obvious that if there's an endometrial tumor, somehow the uterine blood flow should be increased. And you can check it by ultrasound, and you cannot check it by MRI. Or you can check the subendometrial part of the myometrium to check the vascular index and the vascular flow index. We publish some papers about that in case of placenta related to growth restriction or diabetes. Okay,
Yes.
thank you.
Thank you for your comments. With regards to the metastasis which can be detected by magnetic resonance imaging, there are literature data about that metastasis, when the myometrial infiltration is less than 50%, it's quite rare. So this is what actually the myometrial infiltration assessment, what makes myometrial infiltration assessment crucial preoperatively, because if it's less than 50%, then we have to just do the sentinel lymphadenectomy, and if these are negative, then actually we can omit the further therapy possibilities. However, if the myometrial infiltration is more than 50%, then general lymphadenectomy, the pelvic lymphadenectomy, is mandatory. So this is why it's crucial prior to the operation to do this. On the other hand, if we take a look on the fertility preservation, then fertility preservation conform the 2023 issued guideline can be done only at low-grade endometrial cancer patients, but without myometrial infiltration. And basically, there are barely any data on the assessment of no myometrial infiltration or some shallow myometrial infiltration. And in the guideline, they say that, actually we say that both ultrasound and MRI are suitable for the no myometrial or shallow myometrial infiltration assessment. However, there is just a transponation from the deep myometrial infiltration studies. So basically, we are yet to see some studies about the no myometrial or shallow myometrial assessment.
Yes, but let me mention that there is an onco-team discussion in each case, and in case of a positive curettage, then it requires a CT or MRI picture as well. And the next question is, you mentioned that if there is no myometrial infiltration, then we can keep fertility.
Yes, and low grade.
Would you recommend some medication?
Some medication,
For example,
obviously.
I had previously a patient with endometrial cancer proved by curettage, and she was a nulliparous woman at the age of 31 years, and in Romania they recommend to take the uterus out, but she would plan a pregnancy. So what would you recommend in that case?
Fortunately, there is guideline about this, so issued last year. The basic recommendation is that it should be resected by hysteroscopy, okay? And afterwards, the levonorgestrel intrauterine device is strongly recommended, even combined with oral gestagens. Yes, even combined. And as soon as the patient decides to get pregnant, then there has to be an in vitro fertilization. And after the pregnancy is carried to the term, then alongside with hysterectomy, there has to be a C-section.
Yes,
this is the guideline.
That's correct.
Yes,
Yes, we did the same.
Yes.
Okay, thank you.
Yeah. You're welcome.